Hi, good evening, everyone. I hope I'm audible.
Yes, ma'am.
Yeah. So today, Dr. Poonam, Dr. Poonam would be presenting a case on carcinoma of upper alveolus today. So let's start with the presentation then.
Good evening to all the moderators and everyone who is watching. I'm Dr. Poonam, second year DNB ENT at Northern Railway Central Hospital. I'm going to present my case of Mr. Subhash Chand Sethi, who is 56 years old, male, who is traveling ticket inspector by occupation and a resident of Northwest Delhi. He presented to the ENT OPD with complaints of ulcer over the right upper gum since 2 months. He also complained of loosening of the right molar teeth since 2 months. Coming to the history of presenting illnesses, patient was apparently asymptomatic 2 months back. Then he developed an ulcerative lesion over the right upper gum in the molar tooth area, which was insidious in onset, progressive in nature, initially of pea size, now progressed to the present size, with no aggravating or relieving factors. It was associated with pain and loosening of the right upper molar teeth. Pain was dull aching, non-radiating continuous type of pain, which aggravates on spicy food intake with no relieving factors. There is no history of bleeding or discharge from the lesion. There is no history of neck or cheek swelling. There is no history of similar lesions elsewhere in the mouth. There is no history of decrease in mouth opening. There is no history of numbness or altered sensation over the face. There is no history of trauma. There is no history of hoarseness or difficulty in swallowing. There is no history of cough, hemoptysis, or breathlessness. No history of backache or bony pain. There is no history of headache or seizures. No history of abdominal pain. No history of any significant weight loss or loss of appetite. Coming to the past history,
Dr.
the
Poonam,
patient
maybe we can, Dr. Poonam, maybe we can have a little break and we can discuss every, point that you have taken in your negative history for the relevance once.
Yes, ma'am. So there is no history of bleeding or discharge from the lesion. Since it is an ulcer, there could be bleeding and discharge because of any infection. There is no history of neck swelling.
Dr. Poonam, you have taken the history that there's loosening of right upper molar teeth, and you have
Yes,
an
ma'am.
answer you are saying on the same side, right?
Yes, ma'am, on the same side.
Are you able to kind of correlate these, two complaints that the patient has?
Yes, ma'am.
What do you say about it?
Ma'am, there was loosening of the right upper molar teeth which was at the same site where the ulcer is present, because the ulcer could have infiltrated the bone and the alveolar socket, which resulted in loosening of the teeth.
So it's quite a common occurrence that a lot of these patients, they go to the dentist first, with the complaints that they have, pain in their tooth. But eventually, if the pain is relieved, then you say, okay, it was because of the tooth problem only. And in case it doesn't relieve and then an ulcer comes up, then it points, a little towards, yes, a malignancy maybe. Dr. Vadisha?
Yeah. So, Dr. Poonam, you mentioned there is no history of bleeding from the ulcer. How this negative history is going to help you in the diagnosis?
Sir, if there is bleeding, it could also mean that there is active inflammation which is there. So we can think of any inflammatory lesion also. We can think of any.
If there is bleeding, that would have contributed. But if there is no bleeding, will it still contribute, or it is not a very relevant history?
Sir, in this case, even if it does not bleed, there are other positive history which is pointing towards malignancy. So
Yes,
even if it.
Correct, agree with that. So probably the negative history of bleeding is not that significant in this particular case. Of course, if there is bleeding, then definitely it would contribute. And you mentioned about the altered sensation, how it is going to help.
Sir, there is no complaint of paresthesia or numbness. So that means that trigeminal nerve is not involved because that supplies the three divisions of trigeminal supplies majority of the face. So that means nerve involvement is not there yet.
Okay. So otherwise, apart from this loosening the one particular teeth, is he having his all teeth intact?
Yes, sir. All other teeth are intact.
And
Only in
there is
this area he had loosening.
okay.
Yes.
You think this simple growth, I mean, the growth that you've been, I mean, telling us, how do you think it can give rise to, I mean, this altered sensations over the face that you were talking about? You said trigeminal nerve involvement, but how do you think it can happen, I mean, in a lesion like this?
Ma'am, the maxillary nerve gives branches like zygomatic branch, zygomatico-temporal branch, which supplies the upper part of this jaw where this lesion is present. So, since if these divisions gets involved, it can lead to paresthesias um, over the cheek or the nose or upper lip. So that could involve.
Oh.
Yes. So
So,
also there is.
so the neck history that you've taken is no history of any neck or cheek swelling. Neck
Yes, ma'am.
swelling, we understand that it must have had been taken for cervical lymphadenopathy. Why cheek swelling?
If the because it is the lesion is in close proximity to the masticator space, so that could imply that the tumor has not infiltrated in the masticator space. So if there was cheek swelling present, we could have inferred that masticator space is involved.
Look, masticator space usually
Maxillary sinus also, ma'am. Maxillary sinus involvement also.
in a lesion like this where you have an upper alveolar ulcer that is in quite proximity to the upper gingivobuccal sulcus also, and you
Yes,
have
ma'am.
skin in proximity there, so it could
Yes,
have
ma'am.
been a direct spread from there. So mesenteric space has a lot of other ways also of presenting.
Yes, ma'am. Then there is no history of similar lesions elsewhere in the mouth. So there
Why
could be
has
simultaneously there could be um, other malignant lesions present at the same time because of the exposure of the carcinogen to large area of the mucosa. So there are no other simultaneous malignant lesions present, and also we'll look for pre-malignant conditions like leukoplakia, erythroplakia. So there was no such lesion elsewhere in the mouth.
So do you have a name for these lesions if you have, I mean, another lesion in the mouth like this, I mean, that you're talking about?
Yes, ma'am. WHO has recently uh, classified such pre-malignant lesions into oral potentially malignant disorders. Um, it includes the lesions which have higher chances of turning into oral squamous cell CA. Um, it includes leukoplakia, erythroplakia, lichen planus, oral submucosal fibrosis, lichenoid lesions, actinic cheilitis, graft versus host disease.
Okay.
I think Madam meant something else, Dr. Poonam.
Yeah,
So
I
you're
actually
mentioning
meant something else.
something else.
Yes.
The terminology what is used when there are other lesions elsewhere in the oral cavity.
Okay.
So you are mentioning the
We call
pre-malignant
it
lesions,
as second. Yes, sir. We call it as second primary malignancies.
but the
Um,
terminology.
field cancerization. Because of the field cancerization, second field tumors or second primary malignancies can be there.
I think, Madam, would you like to break the clue?
I think we can, yeah,
What
we
is
can probably, I mean,
Fatty.
elaborate it further in the coming,
yes,
my,
yes, yes,
maybe the
definitely. Yes,
points.
yes. I think she can go to the present history, the personal history.
Um,
Sorry, past
he
history. You want to add something? Past history we missed.
um, Not a known case of diabetes mellitus or hypertension or coronary artery disease or cerebrovascular disease. No history of similar illness in the past. No other significant past medical or surgical history. no history of allergy to any medicine, no history of any previous surgery. Coming to the personal history, the patient is vegetarian by diet and there is no history of excessive spicy food intake. Appetite is normal. There is no altered bowel or bladder habits. Sleep is normal. There is
Okay.
history of gutka. Yes, sir.
Sorry, I think we need a break. What is the meaning of excessive spicy food intake? Can you elaborate on that? How it is going to affect, or what kind of spicy food?
It's a ref.
No, since you
He,
specifically mentioned it, we are just curious.
yes, a ref. Like every day if he's eating very spicy or chili food, because spicy food is in turn a risk factor for malignancy. Matlab, it is one of the risk factors.
I think among the five S, probably spicy food is included, but actually that spicy food need not be typically the spicy food what we have. So spicy food includes all those uh, things which are taken with the tobacco. I mean, areca leaves, that is lime and all. So
Yes, sir.
not our day-to-day spicy food. We cannot blame them for the malignant lesions.
Yes, sir.
And okay, of course, spicy food for the mnemonic sake, they have included spicy food as one of the etiological factors, but that is not actually the spicy food what we take day to day.
Yes, sir.
Because next you are telling history of gutka chewing. Probably that is one of the spicy food. What is actually meant in the yes.
Yes, sir. Yes, sir. Because gutka also contains tobacco and lime. Yes, sir, which helps in release of alkaloids, which again is so. There is history of gutka chewing since 25 years. He quit 2 months back. There is history of smoking since 25 years. 10 BDs per day, uh, 12.5 pack years, and that also he quit 2 months back. There is history of occasional alcohol consumption since 25 years.
Is there
History.
any is there any relation between taking alcohol and smoking together?
Yes,
Is there
sir.
any extra adverse effect of consuming this together?
Yes, sir. It increases the chances of cancer because alcohol and smoking have synergistic action. Alcohol acts as a uh, solvent where the tobacco carcinogens are more soluble and are more readily absorbed than the aqueous saliva. So it increases the risk of malignancy if taken together.
Okay. So
Can,
could
can
you
you, yeah,
sorry. Continue, ma'am. Continue.
okay. Can you comment over, I mean, a couple of, active components in gutka, tobacco, or anything, I mean, that you know about?
Uh, yes, gutka contains tobacco and lime. So tobacco has nicotine, um, and the lime, which is present, it helps in the release of these alkaloids along with the erica nut. So which helps in lime helps in release of the alkaloids from the erica nuts. It contains ericadin or ericolin. Then tobacco has nicotine, which is converted to nitrosamines by the anaerobic bacteria present in the mouth. And the other carcinogens, like there have been 30 carcinogens which have been named in tobacco. Some of these are benzopyrenes, polycyclic aromatic hydrocarbons, nitrosamines, nitrosonicotin, nitrosopyrrolidine.
Okay.
Yes.
Ajay.
Coming to the family history, there is
Uh,
no history of. Yes, sir.
Sir, 1 second. I think I had one point in that. Regarding the chewing, like, did you dig more about the pattern of chewing? Because that also important. So just chewing
Yes,
and
sir.
spitting and keeping it. Yes, especially when it comes to the alveolus and the GB cell malignancies,
Right.
there is some interesting history what we get.
Yes, sir. The patient told that he takes gutka from the right side most of the time, majority of the time. He chews it and then spits it out. So it was majority of the time right more than left side.
And also they keep it there for a certain time.
Yes, sir. Coming to the family history.
Dr. Poonam, just one
Yes,
question.
ma'am. Good
Apart
evening,
from
ma'am.
tobacco, good evening. Apart from tobacco, do you think there can be any other risk factor?
Yes, ma'am. Tobacco, alcohol, spicy food, infections by oncogenic viruses, genetics, HPV, human papilloma virus, herpes simplex virus,
Do you think HPV has
HIV.
a role in upper alveolus malignancy?
The research is still going on, ma'am. There is no clear-cut evidence that it causes oral cavity malignancy. More so, it is related with oropharyngeal CS, but still, the research is still going on.
And to be specific, which human papilloma virus are we talking about?
16 and 18.
Hello.
Yes, ma'am.
I was asking, to be specific, which human papilloma virus are we talking about?
HPV 16 and 18 strains, ma'am.
Please go ahead.
Coming to the family history, there is no history of head and neck cancer in any family member. So after the history taking, the summary is that here is a 56-year-old male who is chronic tobacco chewer and smoker with occasional alcohol intake, with no comorbidities or any significant family history, with 2 months history of gradually progressive ulcerative lesion over the right upper gums in the molar teeth area, associated with pain and loosening of the molar teeth. The dull aching, it was associated with dull aching, non-radiating, continuous type of pain, and there is no other significant history. Coming to the examination, in general physical examination, patient was conscious.
Dr. Poonam, what is your differential diagnosis on the basis of history?
Ma'am, on the basis of history, this looks like a malignant lesion. So,
Why do you think it's a malignant lesion? What are the points favoring it to be
because
malignant?
first of all, the gender of the patient, he is a male patient who is in his 6th to 7th decade of life, where generally oral cavity cancer are the most common in 6 to 7 decade of life, and he also has he is also a chronic tobacco chewer and smoker, along with alcohol consumption. So that is also pointing towards carcinogen exposure of the oral mucosa. And
So whenever you are asked about a thing like that, rather than starting straight away from age and sex, I think you should, start talking about other factors first. What do you say? I mean, Dr. Badish and Dr. Deepika. Am I audible?
yes,
Hello?
ma'am. Yes, ma'am, you're audible.
So anything, I mean, Dr. Badish and Dr. Deepika, you'd like to ask? In the history.
I think that's what. Like before going to the examination, one possible differential diagnosis. Of course, here it is more or less clear with the history.
Right.
Yes. Coming to the examination, in general physical examination, patient is conscious, cooperative, well oriented to time, place, and person, moderately built. ECOG score is 0. BMI 24.8 kg per meter square. Pulse rate 84 beats per minute. blood pressure taken in supine position 130 by 76 mm of mercury, respiratory rate 18 per minute. There is no pallor, icterus, clubbing, cyanosis, or lymphadenopathy. Coming to the local examination of oral cavity. On inspection, mouth opening was adequate. Interincisorial distance was more than 4 centimeters. Orodental hygiene poor. Halitosis was absent. Teeth were tobacco stained, dentulous, except for the molar tooth, which were absent on the right upper side.
Dr. Poonam,
Yes, ma'am.
while talking about the lymph node examination, can you repeat the line that you said?
Ma'am, there is no pallor, icterus, clubbing, cyanosis, or lymphadenopathy.
Okay. So which lymph node did you particularly palpate?
Ma'am, level 1, 2, 3, 4, all the cervical lymph nodes.
What do you understand by the term significant lymphadenopathy clinically?
Significant, ma'am, more than 1 to 1.5 centimeter is a significant palpable lymph node.
And clinically, what are the other features which are suggestive of a malignant lymph node?
If there are multiple lymph nodes, more than 1.5 centimeter size, if there is involvement of level 4 or 5 group of lymph nodes, if the lymph nodes are matted, or if the lymph nodes are fixed to the underlying structures, if there is skin involvement, or if there is if there is nerve involvement. So all these features suggest that it could be malignant.
Okay, fine.
Size of 1.4 in any level, or is there any relaxation in particular level?
Sir, for oral cavity, it is more than 1 centimeter for.
No. I'm talking about
Lymph
lymph
node
node
groups.
levels.
Level
Group,
is
sorry.
Groups.
um,
I mean, there are other lymph nodal groups also in the body, right?
yes, sir.
You just mentioned the cervical group. So any other, I mean, parts of the body that you may have lymph nodes. So the criteria may be different for all those lymph nodal groups. I think
Yes.
that's what you
Okay.
mean, Dr. Vidisha, right?
Yes.
Yes,
So
sir.
in level 2, it is up to 2.
Okay. Okay,
And
sir.
what is the other score what we use for performance status? You mentioned ECOG 0 score of 0. What does
Yes,
it
sir.
mean?
That there is that the person is fully active and there is no performance restriction.
Any
The
other
other score
scoring system?
is
What we
Karnofsky
Karnofsky,
scoring
yes.
system.
Okay. What would be
Yes.
the score here for him?
It would be 90, sir. The
Okay.
score would be 90.
Yes,
Okay.
it is the other way.
Yes, sir. Where the patient has no symptoms, but there is no deformity or disability
Yes,
because of the symptoms.
right.
Yes. Coming to the local examination, inspection, I've already told. This was the clinical picture of the patient, and this is the ulcerative lesion. A single right upper alveolus ulcerative lesion measuring about 3 by 2 centimeters seen, which is extending anteriorly till the posterior portion of the right, extending anteriorly till the posterior portion of the right upper second premolar, posteriorly till the last molar region, and laterally it is just short of the right upper GB sulcus. It is lying 2.5 centimeters from the midline medially, with some adjoining erythema also seen. The edges of the ulcer are everted. The floor appears erythematous with slough. On palpation, there was no local rise of temperature. Tenderness present on deep palpation. Mouth opening was adequate. The interincisorial distance was more than 4 centimeters, and the findings of inspection were confirmed with regards to the size and extent of the lesion. Margins indurated. It does not bleed on touch. There was no loose teeth.
Dr. Poonam, the no
Yes.
local rise of temperature, is it very much relevant in this particular case?
No, sir.
No, in which lesion you expect there is a rise in the local temperature in oral lesions?
Inflammatory lesions, sir, where there is like abscess.
Okay. That too in
Yes,
oral lesions, this doesn't carry much value.
yes, sir. Okay, sir.
Okay. So you mentioned margins indurated. How to what distance from the margin of the ulcer it is indurated? Is it
Sir,
till the level of margin or is it extending beyond the ulcer?
no, sir. It is only. It is not extending beyond the margins of the ulcer.
Okay. So what difficulty we anticipate in describing induration in this particular case?
Sir, because the base of this ulcer is also alveolus, so which is bony, so it is difficult to differentiate whether it is indurated or palpating the bone.
So unlike tongue or buccal mucosal lesion, it is not very easy to describe induration in this particular case.
Yes.
Okay. No loose
There.
tooth you mentioned. Sorry. So no loose tooth teeth you mentioned here.
Yes, sir.
But in the
Yes, sir.
history, you mentioned that patient also has some teeth discomfort. Is
Sir,
it
sir, when
matching or did you miss something?
sir, when he presented to the OPD, uh, that had fallen, that loose teeth had fallen. So on
Okay.
palpation, there was no loose teeth.
There was no other question. Fine. Agree.
Yes. No other lesions visible in the entire oral cavity or vestibule. Rest of the oral structures were no abnormality detected. No visible swelling or scars or sinuses in the neck. On oropharyngeal examination was within normal limits. Indirect laryngoscopy was within normal limits. On neck examination, there was no lymphadenopathy. Cranial nerve examination was also within normal limits. So the nose examination was within normal limits. Ear examination was within normal limits. On systemic examination, bilateral normal vesicular breath sounds were heard on respiratory system examination. In cardiovascular system, S1, S2 heard, no added sounds. On per-abdomen examination, no mass palpable. In central nervous system examination, no focal neurological deficit present. After examination, the summary is that here is a 56-year-old male, chronic tobacco chewer and smoker with occasional alcohol intake, with no comorbidities or any significant family history, with 2-month history of gradually progressive ulcerative lesion of right upper alveolus, with everted edges, with no cervical lymphadenopathy and no other significant history.
Probably you could have added with the loose teeth.
Yeah, yes.
Loose tooth.
Yes.
Because how significant is the loose tooth when we come to the management part?
Sir, there
Or
is
even
infiltration.
yeah. So even the disease progress.
So there is infiltration of the bone socket, which would have caused it to fall. So we would also suspect that it could go beyond the alveolar socket, the extension of the bony involvement. So after summary, sir, my provisional diagnosis would be carcinoma of right upper alveolus, clinically T2, N0, M0, stage 2.
Why it is T2?
Sir, because it is about 3 by 2 centimeters on examination. So T2 is 2 to 4 centimeters,
Okay, not more than 4 centimeter in greatest
the
dimension.
greatest dimension.
Okay. So I think even other participant can also answer by typing in the chat box. We are not seeing any answers there. Okay, so your diagnosis with the upper alveolar malignancy of what stage 2.
Yes.
So how
Yes.
will you manage that? Now, one more thing, we'll come back to the point of what we were discussing earlier. So this patient also has a 1 centimeter indurated lesion on the buccal mucosa, which is a 2 centimeter away from the alveolar margin. So what you call that ulcer? Of course, that is also clinically malignant.
If it is present at the
Declaring
same
of
time, sir, we'll call it as a synchronous
yes.
tumor.
Okay. Good. So then you answered madam's question now, Divya ma'am's question. Right, ma'am?
So that comes to the other question: what are metachronous tumors then?
Metachronous tumors are those which develop after 6 months from the diagnosis of the index tumor.
Okay. Are there any criteria given for the second primary tumors?
Yes, ma'am. There is Warren and Gates criteria, which says that uh, the tumor should be distinct and anatomically separate from the first tumor, and there is presence of dysplastic altered mucosa next to the primary tumor, and there should be it should be more than 2 centimeters from the normal epithelium from the index tumor, normal epithelium of the index tumor.
So both these tumors, basically, one, they should be histopathologically proven.
Yes, sir.
Second, you should ensure that one of them is not a metastasis from the other one. So,
Yes.
so this is what is included among the 2 points in the criteria. So this
Yes,
patient
sir.
doesn't have any trismus, right? Dr. Poonam, this
No,
patient doesn't
no,
have any trismus.
no,
But
ma'am.
trismus is a finding that you tend to find in a lot of other, I mean, it's another case, but then you tend to find it in a lot of oral cavity cases, right?
Yes,
So
ma'am.
why do you think, I mean, trismus occurs? I mean, how can trismus occur in cases of oral malignancies?
Ma'am, if first because of any associated pain or infection can lead to trismus. If there is involvement of the masticator space or the infratemporal space can cause trismus. Then if there are associated pre-malignant lesions like oral submucosal fibrosis can also present with trismus.
So what is there in the masticator or the infratemporal spaces, I mean, that causes trismus? I mean, what do you have in those spaces?
If the muscles of mastication gets involved, then that causes trismus.
Can you name those muscles?
Yes, temporalis muscle, medial pterygoid, lateral pterygoid, and masseter muscle.
While answering this question, you also mentioned field cancerization. What exactly is that?
So this concept was given by Slaughter et al., where he told that there is histologically altered epithelium present surrounding the tumor. So there are
Slaughter's field cancerization. Good.
yes, sir. So there are patches. Patches are cluster of cells with genetic modifications. So these patches are the precursor field lesions. So there is clonal expansion of the pre-malignant daughter cells in an already genetically modified mucosa. So there is clonal expansion of these daughter cells into the adjacent tissue, which forms a field, and then there is development of cancer in that particular field.
Good.
So your patient has stage 2 upper alveolar CA. Which
Yes, ma'am.
classification have you used? I mean, you've not mentioned that there. Mention it here.
Yes, AJCC TNM staging classification. According to AJCC TNM staging, it is T2.
Which edition?
8th edition.
Has there been any change in the 8th edition AGCC classifications for oral cancers?
Yes, ma'am. They have added depth of invasion into this classification, and also extranodal extension has also been added for lymph nodes, lymph nodal involvement.
What is depth of invasion?
Depth of invasion is the distance measured from the basement membrane perpendicularly till the maximum point of invasion.
So you
Is
think
depth.
basement membrane can't be seen? So you think, I mean, it can be measured. I mean, should it be included in the clinical staging then? I mean,
Ma'am,
it's a pathological finding, measuring the length from the basement membrane to the deepest part of the tumor tissue.
in expert's hand, it can be measured. It was basically devised for tongue cancers or lip cancers where the depth of invasion can be evident. It is not that important for hard palate CAs or other oral cavity CAs.
And have you, I mean, heard of the term tumor thickness?
Yes, ma'am.
So, I mean, what's the difference between tumor thickness and depth of invasion?
Depth of invasion is taken from the basement membrane till the maximum point of invasion, whereas tumor thickness is from the from the surface of the tumor, uh, from where a perpendicular line is drawn till the maximum point of invasion.
Right.
So,
Right. So you may have an exophytic tumor where you may have a good thickness of the tumor, but the depth of invasion may be less depending on where the basement membrane is.
yes, ma'am.
Yeah.
Since we discussed a bit, what is verrucous carcinoma?
Verrucous carcinoma is any lesion with indurated surface is verrucous.
Indurated or anything? Anything which
Raised
can be
with raised
clarified?
borders. With raised borders. Raised borders.
Okay, what is the classical description? It appears like that is why it is called verrucous.
Yes, sir. Verrucous.
Have you seen any varicose cancer?
Proliferative verrucous leukoplakia.
What does varicose mean?
Exophytic.
Verrucae means in general.
Projections. Projections.
Okay, in dermatology,
Verrucous, you have, I mean,
Verrucous. I don't know, sir.
no problem. No, that is why that terminology has anyone here in the
Cold.
students. Sorry, cauliflower like anything? No, better terminology. I think cauliflower. Not Adams. It is something else. Somebody mentioned is Adams. It is not Adam. It is Ackermans, of course.
what is? Someone is measuring.
Warty, yeah. Yes, warty. Good. Verruca means what? Right. So warty
What?
appearance.
Yeah.
Okay. It
Okay.
is a good disease or bad disease in general?
Um,
Verrucous.
Verrucous. So for surgical excision, these are better lesions because can be easily excised.
Okay. Rather than easily excise, what is more important to the patient? For a surgeon, yes, easily
Free
excise. But for the
margins. Free margins.
patient, it won't invade. Okay. It comes onto the surface but won't invade. It is a well differentiated or poorly differentiated?
Well differentiated.
It's a well differentiated. Good.
But what is the problem you have with verrucous carcinomas? I mean, you have a verrucous, lesion. What can be the problem associated with it?
There is high suspicion of malignancy in verrucous growth.
Yeah, look, after you've seen a growth which is verrucous in nature, what would you like to do? In order to justify, in order to prove your diagnosis, what do you do next?
I would like to take a biopsy from the growth.
So do you find any, do you encounter any difficulty in biopsying these lesions, these verrucous lesions?
There can be false negative.
Right. So at times, I mean, the sample may not be representative. You may have to take repeat biopsies in this case. You may have to take a deeper biopsies. So whenever you have a lesion like this, you should be more vigilant in taking biopsy. You should take a more representative and a deeper biopsy in these patients.
Yes, sir.
Usually, verrucous carcinoma are overdiagnosed by clinicians and underdiagnosed by pathologists. That is what is mentioned in the publications. And
Right.
somebody has also mentioned the bad response. I think it won't respond to RT. That is also one of the difficulties probably in the
Right.
treating.
Right.
So shall we go to the management part?
Yes.
Dr. Poonam, how will you manage?
Yes, sir. So I would like to take a biopsy first from the ulcerative lesion, and I will do routine blood investigations. And I too like to,
Madam has asked this question. Ulcerative lesions, where exactly? From the center?
sir, with the surrounding margin.
Correct.
Yes.
It should
So,
always be from the most representative area.
representative area.
So yes, in an ulcer, obviously you'd not like to take it from the center because there may be a lot of necrosis and you may get a falsely negative result. So it has to be like, I mean, from the surroundings. But when you answer, you should answer like, I mean, a more representative area rather than just saying, yeah.
Yes, yes. After taking a biopsy, I would like to do all the routine blood investigations, and I would like to do PSC workup for this patient, and and CT face and neck, along with, yes, CT face and neck.
Include sinus? Face includes? You are interested in sinus too?
Yes, sir.
Would it be a plain CT?
Contrast enhanced CT.
So you have to mention that when you're telling about the radiological investigation that you intend to take.
Yes, sir.
Is there any special thing that you like to do when you are taking CT scans for these patients?
I would ensure that the puffed cheek
Yes.
can be taken by puffed cheek.
Right. Right. Your voice is not audible, but I mean, like, yeah, it is coming in echoing. Yeah, puffed cheek. Yeah, you'd like to take it with puffed cheek. Why would you like to, I mean, take it with a puffed cheek?
Because then the vestibule is properly visible,
Right.
and we
Right.
can easily delineate if the labial sulcus is involved, or we can easily make out.
Right. Right. So would you like
What
to
do you
get
want
an
to?
MRI also done for this patient? I mean, you said that you'd get a contrast enhanced CT scan done. Would you like to get an MRI also in this patient?
Yes, ma'am. CT and MRI can be complementary sometimes for better visualization of the spread of the tumor. Also, MRI gives better soft tissue delineation, and it can also show medullary bone involvement and nerve involvement better than CT.
In your patient, do you think an MRI would be required?
Um, um, in this case, ma'am, CCT would suffice. In this case, it is not compulsory to get an MRI done.
Yes. So what would be the clinical findings where you may like to get an MRI done along with a CT scan? Which all cases?
if ma'am, the disease is T3 or T4 clinically, if there is nerve involvement, if patient complains of numbness or paresthesias where we are suspecting that there could be nerve involvement, I would like to get an MRI done. And if the masticator muscles are involved, so muscle involvement also can be better visualized on MRI.
So what would the patient have clinically? Muscle involvement you'd be deciphering after you get a scan.
Yeah. Yes,
Trismus.
ma'am. Trismus.
If your patient has trismus, then definitely you'd like to get an MRI done. But okay.
In a tongue malignancy, which would be a better option?
MRI would be a better option, sir.
Why MRI would be a better option than CT?
Because here we are we are suspecting bony involvement of maxilla or mandible, but in tongue CAs, we'd like to see the involvement of the muscles of the tongue or the floor of mouth, which is better visualized on MRI.
Correct. For soft tissues, why you think MRI is a better option? What makes MRI superior? Basically, the physics of MRI. What content of the tissue makes it superior?
Water
Exactly.
Right.
I think Dr. Poonam is facing some signal issues.
Right.
I think Dr. Grishma is also telling not. Yes. Dr. Grishma, it is the water content which makes MRI, what content in the soft tissue that makes MRI superior than the CT scan. Is that what you wanted to know, Dr. Grishma?
I had a connection problem, sir. I didn't hear.
We understood. We understood. I think Dr. Grishma wanted to know the answer again. Okay, yeah, fine. So she's convinced. Okay. So you want to get a CT scan done here. Like what all the things what you want to know in the CT scan? In this case, you have only 10 minutes left, I think. We have
Yes. Involvement of maxilla, whether maxillary sinus is involved, if the skull base is involved, if the masticator space is involved, pterygoid plates are involved or not. Then encasement of the carotid artery. If there is invasion of through the cortical bone.
Okay, cortical erosion, probably that is one of the things what is important in decision making. Anything else in the neck?
Lymph nodes.
Subclinical.
Yes, sir. Subclinical lymphadenopathy.
Fine. So shall we go to treatment, madam?
Yes, I think we can proceed towards
Yes. So if the radiological investigations also support your diagnosis, clinical diagnosis as T2, N0, M0. So what would be the best treatment option you give, considering his age and the occupation, and of course the disease?
Sir, I would like to do a wide local excision of the ulcerative lesion with 1 centimeter of free surgical margins, along with elective neck dissection on the ipsilateral side, selective neck dissection on the ipsilateral side.
So how are you going to achieve that wide local excision in this case? I mean, in such cases, we don't call it wide local excision. So we like to, I mean, put it in other terminologies.
Yes, ma'am. So I would like to do a partial maxillectomy for this patient with selective neck dissection on the right side. Infrastructure maxillectomy.
Right.
Yes.
Infrastructure
Probably
maxillectomy.
infrastructure maxillectomy would be a better option, a better answer. Right.
better answer.
Right,
Right.
rather than mentioning partial. Good.
Why would you like to address the lymph nodes here? I mean, why would you like to get a selective neck dissection done in this case?
Because, ma'am, there is about 27% risk of occult metastasis with oral cavity CS, matlab with hard palate or alveolar CS. So, we would like to do elective because it is an indication for elective neck dissection where we can remove level 1, 2, 3 because there is more than 20% risk of occult metastasis. So even if there is N0 neck, we would like to do a elective neck dissection.
Okay. Have you heard of the term skip metastasis?
Yes, ma'am.
What is that?
Skip metastasis is generally for tongue CAs where the metastasis directly occurs to level 4 lymph nodes, skipping the first 3 levels.
Okay. So how would you like to repair this defect? I mean, you've done an structural maxillectomy, and then how do you plan to repair this defect?
We can use flaps to reconstruct the defect. It could be local flaps or it could be pedicled flaps. Local flaps may we can use buccal temporalis flap, or pedicle we can also use radial artery free forearm flap.
So radial flap is not a pedicle flap.
Sometimes if the lesion is small, like it can heal by secondary. Primary closure can also be done where it can heal by secondary intention. And obturator flap can also be used.
Sorry, obturator?
Radial free, yes, these only, sir. Either we can do a primary closure or we can use a temporalis flap repair or radial artery free forearm flap repair.
So I think there is one question for you. What is infrastructure maxillectomy exactly?
Sir, infrastructure and suprastructure maxillectomy is classified based on a line, imaginary line drawn from the medial canthus of eye to the angle of the mandible, which is called as Orngren's line. So the structures, like the part of the maxilla below this line is removed. When it is removed, it is called as infrastructure maxillectomy.
What are the
There,
things okay, removed in infrastructure? Mainly?
mainly, sir, palate resection with alveolus.
Alveolus. The alveolar process, because in this particular case, what is more important is the alveolar process.
Alveolar process.
Okay, and also if you remove the palate also, then also it is inferior, I mean, infrastructure maxillectomy.
Yes, sir.
So it is not exactly according to the Orngren's line that you're talking about.
Yes.
I mean, you're taking out the lower part of the maxilla basically, leaving the orbital floor, etc. That would all come in the infrastructural maxillectomy. And you can kind of, I mean, taper down, you can kind of, decide it on the basis of, I mean, your extent of tumor.
Okay, ma'am.
So what is, you talked about the Orngren's line. So what is the significance of this line?
Ma'am, any tumor involvement below this line has a good prognosis, where if the tumor involvement extends beyond this line, it has poorer prognosis.
And why is that so?
Because there is orbital content involvement. So
There can be, yes, there can
there
be
can
orbital, skull base,
skull base.
your masticator IFT spaces. Okay. Okay.
When will you decide if there is any need of adjuvant treatment for this patient?
Sir, after the histopathological report, in this case, if there is positive margins, or if there is
Yes. Again, Dr. Poonam is offline now. I think Dr. Vaishnavi has asked, will you repeat the answer for the question in which clinical findings both CT and MRI are done? We were discussing about the importance of MRI, especially in cases where the soft tissue involvement is to be decided, especially tongue and base of tongue. And when it is going to the masticator space, we need to do both CT and MRI because we need to delineate both CT, both the bony as well as the soft tissue structures. I think Poonam is back.
Sir, if there are positive margins or extranodal extension, we would like to give chemoradiation. If yes.
Positive margins or extranodal extension, you said.
Yeah, extracapsular spread, ma'am, will give chemoradiation. If there is lymphovascular invasion or perineural invasion, which is seen, we'll like to give radiotherapy for this patient.
Right.
As you mentioned chemo, what are the chemotherapy agent commonly used in oral squamous cell carcinomas?
Sir, we can use cisplatin, fluorouracil,
And of
in
late,
oral. Yes, sir.
and of late, I heard cisplatin and fluorouracil. Anything else? Any drug better than cisplatin 1? And other drug which is usually combined with that? Yes. Dr. Jiten has mentioned cisplatin Taxel. Anything better than cisplatin? Of course, little expensive. Of course, platin derivative only.
Immunotherapy, sir.
Carboplatin. No, of course. Carboplatin already Grishma has mentioned.
Okay, sir.
Taxel carboplatin are one of the combinations, popular combinations in oral squamous cell carcinomas.
Okay.
For ENT, of course, what is the main adverse effect of cisplatin? Since you're ENT. Yeah, I think somebody has mentioned, answered here.
Yeah.
Okay, ototoxic. Good. Okay.
Poonam, how do you look for oral submucosal fibrosis?
Ma'am, based on there are various grades which are given for oral submucosal fibrosis by passing. So grade 1 is when the interincisoral distance is 3.5 centimeters and with associated symptoms of burning, ulceration, and less than 1/3 of the oral cavity is involved. In grade 2, the interincisoral distance becomes 2.5 to 3.5 with palpable fibrotic bands on the soft palate. In grade 3, the interincisoral distance is 1.5 to 2.5 centimeters with palpable fibrotic bands over the soft palate, hard palate, floor of the mouth, tongue, where there is more than 2/3 of the oral cavity which is involved. And in grade 4, the interincisoral distance becomes less than 1.5 centimeters with associated pre-malignant lesions like leukoplakia or erythroplakia.
Okay.
So the patient presents with trismus or xerostomia or fibrotic bands or burning or ulceration complaints.
Okay. So what are your views about leukoplakia? Are all the leukoplakias dangerous?
Like WHO has defined leukoplakia as any white plaque of questionable risk, which is non-scrapable and cannot be classified into any other lesion. So there are homogeneous.
Dr. Poonam, your voice is cracking, I think. There's some problem with the connection.
Yes, ma'am. There is homogeneous and non-homogeneous leukoplakia. Non-homogeneous leukoplakia has nodular, verrucous, or speckled forms, so that have higher chances of malignancy. And also, if the leukoplakia, the size is more than 200 millimeters square, it also has a higher suspicion of malignancy.
Good. Any particular sites, I mean, where you may find leukoplakia that should, ring the alarm?
Floor of the mouth or buccal mucosa. More than 70% of leukoplakia is present on the buccal mucosa.
But not all of them need to be given that much consideration. But if you have a leukoplakia, as you mentioned, on the floor of the mouth or maybe the lateral border of the tongue, then yes, I mean, you may need to biopsy that rather than just, waiting and watching. Okay. So PET scan, I mean, when do you get PET scan done in oral malignancies? Not in your case, I mean, it's not required in your case, but I mean, just for the sake of discussion.
Ma'am, if the patient would have presented with multiple lymph nodes or level 4 or 5 group of lymph nodes, or T3 or T4 stage of disease, or if patient is also complaining of breathlessness or hemoptysis or chest pain or bony pain, then we would have got a PET-CT done.
So basically, in a locally advanced tumor, you'd like to get it done?
Yes,
And in
ma'am.
a recurrent carcinoma case also, you may like to get a PET-CT done. And then,
Yes,
as you
ma'am.
mentioned, if you're suspecting, I mean, a metastasis or, I mean, a second primary somewhere.
Yes, ma'am.
So I think someone was asking how to manage leukoplakia and erythroleukoplakia. Any comments over that, Dr. Poonam?
Ma'am, we would take a biopsy after after the initial presentation, we would like to give systemic topical or systemic treatment for 6 weeks. After observation for 6 weeks, we would like to take a biopsy from that site, and if there is no dysplasia, then we would just observe follow-up every 6 months.
Any particular kind of biopsy that you'd like to take from leukoplakias? Would you take a punch biopsy?
No, ma'am, we will take a wedge biopsy. We would like to take a wedge biopsy.
Knife, I mean, a biopsy or incision biopsy is preferred in these cases. What are the chances of a leukoplakia turning into malignancy and an erythroleukoplakia turning, I mean,
It is about 17%. With leukoplakia, it is about 17% chance of turning into malignancy, and for erythroplakia, it is about up to 40%.
so these percentages should always be told in ranges. Like you said, up to 40% in erythroplakia. It kind of varies, like, I mean, from 1.5 to 17 in leukoplakia, not per se 17. Depending on the, where the leukoplakia is and how it looks like.
Yes, sir.
Would you like to give any chemo preventive medication for this leukoplakia patient? If yes, what drugs? Chemo prevention.
So we can try steroids.
Unmute yourself.
Sorry. Steroid are not chemopreventive drugs, but what chemopreventive drugs that can be used? Usually that is given for these patients.
Right. If a patient, just comes to you with, grade 1 OSMF or leukoplakia, what drugs, I mean, you can't just, send these patients back home without giving anything. They won't be satisfied. So what, you usually, tend to give these patients?
We can give them antioxidants and
Right.
We can give antioxidants, betadine gargles, or vitamin B complex.
Povidone gargles are not preventive, of course, but
Right.
antioxidants, vitamin A, curcumin, these are the chemopreventive drugs.
Okay.
Yes. I think,
Anything? Yes.
anything anyone may like to clarify, otherwise, yeah.
Anything from Dr. Poonam?
Um,
Mhm.
Of course, participation from the candidate is impressive. Good.
Okay, for Dr. Vidisha, we can, I mean, call it a
Yes.
day then. Yeah.
Yes. Good.
Thank you.
So I
Thank you.
think we have
Thank you,
discussed
sir.
everything starting from history, examination, investigations, management. I think most of the things are covered. Of course, 1 hour is not enough to completely comprehensively discuss, but for exam point of view, these are the things which have been discussed. Probably you can go back and read more about some of the questions what you could not attempt, of course, because this is not the end of anything.
Right. Mhm.
So otherwise, Dr. Poonam has presented well, I would say. Though I should not be
Thank you.
judgmental. Yeah.
Mhm.
Thank you very
Thank you
much.
all trainee faculty members for joining this session.
Thank you.
Thank you.